Okay, so well presented. This is the job of a good presenter, that he or she makes the things simpler, easier. या ज़्यादा complicated चीज़ें तो बुक्स में भी लिखी हुई हैं, लेकिन जो समझाना है वो प्रेजेंटर का काम होता है. तो making the things easy. So what is the resolution power of OCT? Five क्या? Oh, okay. So 5 micron meter is the limit of resolution of OCT. So you can detect changes of 5 micron in retinal nerve fiber layer. You see, if the retinal nerve fiber layer is, let's say, 100 micron thick and thinning occurs by 5 micron, you can pick it. So this is the earliest change which we can detect in glaucoma. In 1990, when I was studying for my fellowship, there was a reference of Quigley, which stated in 1980s that when first scotoma occurs in glaucoma, 30% of the ganglion cells are already dead. So neuronal damage, extensive neuronal damage has occurred before it becomes perimetric. So now we are addressing the diagnosis at peri or pre-perimetric stage. So previously we were bound by the visual field only. So when there was a scotoma, we were sure that this is a glaucoma. Until and unless we did not see a scotoma, we will not label a case as glaucoma. But now we can detect glaucoma before the scotoma appears. So that's why OCT has replaced all other investigations. And among the 3 or 4 tests you have mentioned, RNFL thickness, optic disc measurements, ganglion cell thickness, and anterior segment OCT, retinal nerve fiber layer is the most sensitive indicator that the damage is occurring. So you can have serial OCTs and you can detect the change, and you can have softwares where the progression of the glaucoma can be assessed. Whenever OCT comes to you, the first thing you see is the signal strength. If the signal strength is less, this OCT is not reliable. So normally 7 out of 10 is the minimum acceptable value. Second thing you see in OCT is the presence of artifacts. What are the different artifacts? Like motion artifacts, broken lines. If the scan is not continuous and uniform, it means there is some interruption of data, and that scan is not reliable. See, it gives false readings. So you have to detect the motion artifacts, dryness artifacts, and there are 5 or 6 types of artifacts. I sent you the book yesterday. किस किसने देखी थी? आपने देखी थी? ओके. सो गुड. तो उसमें आर्टिफैक्ट्स भी सारे डिटेल से दिए होंगे. सो दिस इज द सेकेंड थिंग which you look for. The third thing, then you come to retinal nerve fiber layer. What is the thickness? What was the thickness in the previous scan, and you compare the two figures. Regarding the macular ganglion cell layer, you see, half of all the ganglion cells are in the macula. So if there is any decrease in the macular ganglion cells, that can be detected early. If the thickness of the, let's say, retinal nerve fiber layer increases, what color would be there? White. Papilledema. So in papilledema, the layer would be white in color. Instead of the line would be in white range instead of being in the green. Any other example of increased thickness? Myelinated nerve fibers. the retinal thickness is increased. Now, if a patient comes with myelinated nerve fibers and develops glaucoma, how will you detect? देखे ना वो उसकी थिकनेस पहले ही ज्यादा थी, अब वो कम हो रही है फॉर एग्जाम्पल। सो उस वक्त हम मैकुलर गैंग्लियन सेल्स की तरफ जाते हैं, because the macula is not involved. It is usually the myelinated nerve fibers are on the disc margin. So this ganglion cell thickness helps you whenever there is confusion in the RNFL stage, right? So what is the other investigation that we can do if we do not have the anterior segment OCT? Ultrasound biomicroscopy. This is called UBM. So they are almost of the same quality. Now OCT is having more resolution, so you can analyze the angle of the iris with the cornea and trabecular meshwork and all other things. So try to see our OCT gives reading of RNFL only, I think. It does not give reading of optic disc. डिस्क डायमीटर, कप डायमीटर, कप डिस्क रेशो, तो जाके देखें, डिस्कस करें ओसीटी टेक्नीशियन के साथ क्यों नहीं दे रही, और तीसरी जो मैकुलर गैंग्लियन सेल लेयर है वो क्यों नहीं दे रही। तो आइडियली वी शुड गिव, अगर प्रिंट नहीं निकालना चाहते पेशेंट को कहें कि भाई मोबाइल से इसकी फ़ोटो खींच लो, ठीक है। अगर हम फ़र्ज़ करो पेपर कभी ख़त्म हो जाता है या हम इकोनॉमी करना चाहते हैं, बट you should know that the machine can give you all the three prints. अगर आप लेते नहीं है तो ये आपकी सुस्ती है। So another interesting scenario is myopia, in which the retinal, the optic disc is thin, shallow, and the cupping is not that marked. So similarly, the parapapillary atrophy. So don't know where the disc starts and where the disc ends. So there you have the concept of BMO, Bowman membrane opening, from one end to another end. Actually, the OCT technician should focus the BMO so that the readings are reliable. इसमें भी आपको गाइड करना पड़ेगा कि भाई ये कैसे इसके में। So these are the advancing sort of edges and you can make use of. 8:45 बजे सर ने कहा हुआ है ख़त्म करने। Any last minute question, comment?